السلام عليكم. بيسعدني ان احنا نبدا السيشن اللي هيشرفنا فيها الدكتور شريف عمر، شركه ليبتس. الحقيقه عامله لنا سبورت جامد جدا من اول يوم بدانا الجمعيه، واحنا فيري جريتفول لهم، ويعني اتمنى التعاون ده يستمر على طول ان شاء الله، وانتوا تستفيدوا واحنا نستفيد ان شاء الله. الف شكر. اتفضل. البرزنتيشن بتاعتك هتبقى على الهايبريوريسيميا وعلى الدي في تي بريفنشن. اتفضل. شكرا.
Thank you. Well, good afternoon, everyone. It's a pleasure to be here at the Egyptian Arthroscopy Association annual conference. As mentioned by the good professor, we are very proud supporter of this annual event, and we are happy to participate every year. So thank you, Professor Adel and Professor Ahmed, for inviting us to attend with the session this year. So at Liptis, we've been expanding our product portfolio, and the number of products that are on the market continue to increase in the Egyptian market and overseas. So we have a presentation to review some of the key launches and recent products in our portfolio. We start with Unsiatem, our febuxostat brand of 40 to 80 milligrams for treatment of hyperuricemia in patients with gout. You know, gout, as we know, is the most common form of inflammatory arthritis. The prevalence has risen in recent decades. Studies show that 60% of patients will experience a recurrent gout flare within 1 year of the initial manifestation, and 78% will experience a flare within 2 years of the first onset. Advanced gout is associated with reduced mobility and quality of life. It affects multiple facets of a person's life, with walking being the most pronounced area of impact for patients that have repeat gout flares. And so hyperuricemia is the most important risk factor for the development of gout. A high blood uric acid is associated with a statistically significant increased risk of death from cardiovascular disease, stroke, congestive heart failure, or any cause overall. The ACR and EULAR guidelines for the management of gout is to bring the serum urate levels down to less than 6 milligrams per deciliter, or a target of less than 5 in patients with severe cases. Overall, the minimum reduction is to less than 6 milligrams per deciliter. Now, xanthine oxidoreductase is the chemical that is most important to address in the treatment of hyperuricemia, because this catalyzes the oxidation of hypoxanthine into xanthine and further catalyzes it into uric acid. And there are two forms of the enzyme. There's the oxidized and the reduced form of the xanthine molecule, either xanthine oxidase or a xanthine dehydrogenase. And so Unsiatem is the Liptis brand of febuxostat used to treat patients with gout in managing their hyperuricemia. The mode of action is broken up into two locations. Both of them impact the conversion of the hypoxanthine to xanthine and further conversion of xanthine into uric acid, because the febuxostat in Unsiatem inhibits both the oxidized and reduced form of xanthine oxidase. In fact, Unsiatem is a non-purine selective inhibitor of xanthine oxidase, 10 to 30 times more powerful and potent than allopurinol, and because it is a non-purine inhibitor, it has no effect on purine or pyrimidine metabolism. When the comparison was made between Unsiatem and lowering serum uric acid versus allopurinol, there are several studies that have been published. This particular study involved over 4,000 patients, and the outcomes showed that the reduction of serum urate from baseline was most pronounced with the febuxostat Unsiatem compared to allopurinol, and certainly much more than placebo. Unsiatem showed a higher rate of achievement of target serum uric acid, whether the target was 6 or 5 milligrams per deciliter, compared to the achievement by allopurinol. In fact, patients whose target was 6 milligrams achieved a reduction in 60% of the patients compared to 38 in allopurinol, and for those with a lower target level, it achieved in 42% compared to only 15% of success in patients taking allopurinol. The time further to reach the target levels was lower with the febuxostat or Unsiatem compared to the allopurinol. About 86 days where the target was 6 milligrams, and a further 53 days compared to the 90 days in patients taking allopurinol. So the conclusions: in patients with gout and hyperuricemia, Unsiatem is significantly more effective and faster than allopurinol in achieving the recommended target serum uric acid levels, and Unsiatem is confirmed as an effective option for the treatment of hyperuricemia in patients diagnosed with gout. When we look at patients that have elevated levels of serum uric acid and calcium stones, in this particular study, there is a comparison of febuxostat, allopurinol, 300 or 200 milligrams depending on renal function, and placebo. And the outcomes showed that the reduction in baseline urinary uric acid excretion was dramatically more pronounced in the patients taking Unsiatem, 59% compared to 39% in allopurinol, and 59% compared to 36% at 6 months in the reduction of urinary uric acid excretion. So Unsiatem at 80 milligrams significantly lowers 24-hour urinary uric acid excretion, much more than allopurinol in stone formers with high urinary uric acid excretion. Febuxostat, in this particular study for cerebral and cardiovascular events prevention study, which involved over 1,000 patients comparing febuxostat and allopurinol over 3 years, here the secondary endpoint was deterioration of renal impairment, which was dramatically lower in patients taking Unsiatem as compared to those taking allopurinol. The secondary endpoint looked at the cardiovascular disease and all causes of mortality. And so in terms of safety, both products were quite similar. And in fact, when we look at the outcomes, arteriosclerotic disease, heart failure, or death was lower, in fact, in the febuxostat group than the allopurinol group. Remember, uric acid, the problem is not just the manifestations in terms of kidney stones or in terms of gouty flares. There is overall increase in mortality for patients with elevated serum uric acid. And using febuxostat can help address the all-cause mortality. The indications for Unsiatem is the chronic management of hyperuricemia in patients with gout, kidney stones, and tumor lysis syndrome. The dosage is 1 40 milligram tablet daily. After 2 weeks, if the target reduction in serum uric acid is not achieved, then the dose should be increased to 80 milligrams once a day. So when you treat your patients, you should reevaluate them after 2 weeks, take the blood levels and make sure they're within the target range. If not, then double the dose to 80 milligrams once a day. There's no interaction with food, can be taken with or without food or antacids. Adverse reactions, the most common are liver function abnormalities, nausea, arthralgia, rash, and dizziness. If patients have moderate renal impairment, no dosage adjustment is required. If the creatinine clearance is less than 30, there's insufficient data to support use, and so it is not recommended. Furthermore, if patients have mild or moderate hepatic impairment, class A or B in the Pew level, no adjustment is required. If it's severe hepatic impairment, again, no studies have been conducted in those patient populations. Pregnancy category C and should be avoided for breastfeeding mothers. After initiation, when there's a gout flare, you should provide prophylaxis with NSAIDs or colchicine upon initiation for about 6 months, because once you start to reduce the serum levels of uric acid, that can cause mobilization of the urate stores and can trigger another gouty attack. And so we want to avoid that by concurrently treating the patients with NSAIDs or colchicine. If the patient is already receiving treatment, then it's not necessary to discontinue therapy during an attack. It may increase liver enzymes, and so we want to obtain the panel of liver function tests, the baseline, and do not initiate if you're outside 3 upper levels of normal in the AST, or total bilirubin is more than 2 times the upper limits of normal. The contraindication is only for patients being treated with azathioprine or 6-mercaptopurine. So when we look at the comparison of Unsiatem versus allopurinol, Unsiatem is a non-purine analog. It's a selective and potent inhibitor of both forms of xanthine oxidase, does not affect other enzymes, so it does not impact purine or pyrimidine synthesis. Starting dose is 40 milligrams a day to increase to 80 milligrams a day if not brought under control within 2 weeks. No dosage requirement necessary for patients with mild to moderate renal or hepatic impairment, and no hypersensitivity has been reported. Dosage is 1 tablet daily for patients suffering from gout, kidney stones, or tumor lysis syndrome. 40 milligrams a day. After 2 weeks, you can increase to 80 milligrams if sufficient control is not achieved. So Unsiatem is a potent selective antioxidase inhibitor, more effective in lowering serum uric acid levels than allopurinol, faster onset of effect, with a safety profile comparable to allopurinol. Delays the progression of renal dysfunction. Unsiatem needs no dose adjustment in mild to moderate renal or hepatically impaired patients, few drug-drug and drug-food interactions, and is a convenient once-a-day dose. Unsiatem is available now in Egypt and in fact has been shipped to several other countries around the region. Vaxato, you know quite well, is our brand of rivaroxaban, 10 milligrams, a trusted name in prevention of DVT. We know deep vein thrombosis incidence can be 40 to 60% in patients undergoing major orthopedic surgery. Of course, the main complication of DVT is life-threatening pulmonary embolism. Patients afflicted may die within 1 month of diagnosis in 10 to 30% of the cases. 30% of those with DVT or PE will have a recurrence within the next 10 years. And so when we look to assess the patients, it's important to develop a risk factor assessment. And this algorithm, essentially just a simple sheet where you can identify the risk factor score by adding the scores across the various items, can show you that patients of 5 or more are at the highest risk of developing DVT, and for them a factor Xa inhibitor is among treatments indicated for prophylaxis. But when you look at patients in cases that are not as aggressive, an obese patient with a leg plaster who is elderly, in fact this patient achieves a risk factor score of 4, and 4 is still considered high risk for developing of DVT. In those cases, factor Xa inhibition is still indicated as prophylaxis. The American College of Chest Physicians has their guidelines on the prevention of venous thromboembolism in orthopedic surgery patients. Rivaroxaban is among the category of drugs class 1B to be used for prevention of DVT in patients undergoing total hip or knee arthroplasty, as well as for major orthopedic surgery. Vaxato is a direct factor Xa inhibitor. Inhibiting one molecule amplifies the reduction of 1,000 thrombin molecules because it impacts both the intrinsic and extrinsic pathways that make up the blood coagulation pathway to coagulation. When we look at patients that look at thromboprophylaxis after knee arthroscopy, in this particular case, it was a 60-year-old patient undergoing arthroscopic meniscotomy, no personal history, but her sister had pulmonary embolism after pregnancy, and she had a BMI of 31. Evidence shows that even patients with arthroscopic surgery, certain patients are at risk of venous thromboembolism. If we categorize her risks across this scheme, we see that her total score is 8. She's obese, family history, elderly, and arthroscopic procedure greater than 60 minutes. And so she, in fact, is at high risk of developing DVT, the highest risk. Her score was 8, which is well above the 5 threshold, determining the highest risk patients. There was a randomized trial involving patients undergoing knee arthroscopy, showed a benefit of VTE prophylaxis with low molecular weight heparin and with rivaroxaban. Rivaroxaban was studied for thromboprophylaxis for non-elective orthopedic trauma surgery in Switzerland on over 400 patients. They were randomized, half received rivaroxaban, half received the standard of care, and in fact, in the outcome, essentially was you had a 50% reduction in the incidence of any symptomatic thrombotic event, and 50% reduction in a venous thromboembolic event for patients that were given rivaroxaban as compared to the standard of care. The conclusion is that the rivaroxaban is an appropriate oral alternative to prophylaxis and can be used instead of injectable medications for patients that are non-compliant. Recently, the FDA has approved a new indication for rivaroxaban for the prevention of VTE in hospitalized, acutely ill medical patients at risk for thromboembolism, but not at high risk of bleeding. In the study published in the New England Journal of Medicine, it looked at rivaroxaban for thromboprophylaxis in acutely ill patients. In this particular study of over 8,000 patients, they were randomized to receive subcutaneous enoxaparin versus oral rivaroxaban for up to 5 weeks. And so the primary outcome was looking at asymptomatic, proximal, or symptomatic VTE up to 10 days and up to 35 days. The results showed that the incidence was about the same at 10 days, but at 35 days, patients taking rivaroxaban had a reduced incidence of VTE compared to those taking enoxaparin. In terms of safety, non-major bleeds were quite similar for both, and it shows here that extended duration of rivaroxaban reduced the risk of venous thromboembolism, and there was a slight increase of bleeding in the patients taking that medication. And so the idea here in using rivaroxaban, the contraindications, of course, are hypersensitivity to any of the components, hepatic disease with active coagulopathy, clinically significant active bleeding, pregnancy, or lactation. When we look at drug-drug interactions, some drugs will increase the risk of bleeding, others will reduce the efficacy, and that's why we have online, you can download a Vaxato app which keeps track and confirms to you all the drugs that may interact to increase or reduce the efficacy. For patients with creatinine clearance greater than 30, it is safe to use. 15 to 29 can be used with caution. Less than 15, use is not recommended. No dose adjustment is required otherwise in elderly patients. If there are cases of overdose, then bleeding should be management according to the severity and location of the hemorrhage. In Egypt, they have Nova 7 available that can be used to manage any overdose with a single IV bolus. The algorithm to treat bleeding is well known, and it's available on the application that you can download off Google Play or the App Store. And so when we look at the use of Vaxato as prevention of DVT, we have to balance any risk of bleeding, which is minimal, compared to the risk of pulmonary embolism, which can lead to death, cost of treatment, cost of recurrence, and other complications. So Vaxato 10 milligram is indicated for the prevention of VTE in patients undergoing total hip or knee replacement or hip fracture surgery, and the dosage is 1 tablet, 10 milligram tablet daily, 6 to 10 hours after surgery. For patients undergoing hip surgery, it's 5-week duration. Those undergoing knee surgery, it is 2 weeks of recommendation. It should be given up to 2 hours before the next scheduled dose of the low molecular weight heparin. We package it in aluminum blisters to protect the active integrity of the active ingredient from any light degradation. This maintains the integrity of the active ingredient and protects it from any degradation from moisture or light or humidity, no matter where it is stored. Rivaroxaban and Vaxato is offers superior efficacy compared to other anticoagulants. It's a higher safety profile compared to enoxaparin, avoids heparin-induced thrombocytopenia, has better patient compliance. It is oral instead of an injectable treatment. No need for dose adjustment in moderate renal impairment or the elderly, and no need for INR monitoring with a low interaction of food and other medications. Vaxato 10 milligrams is available across Egypt and the neighboring markets. Our final recent introduction is Prenolax, the first and only extended release muscle relaxant. It's a 24-hour acting cyclobenzaprine 30 milligram capsule. We know cyclobenzaprine is a well-known product used for many years with efficacy that is well known. The challenge, of course, is the dizziness and somnolence associated with the immediate release dosing. This causes many patients to use only 1 tablet at bedtime, and then they lose the benefits during the day. Prenolax is manufactured using a unique DiffuCaps technology where the active ingredient is embedded in multiple layers of polymers to enable slow release over a 24-hour time frame. This reduces the adverse effects and provides a consistent and sustained efficacy of the active ingredient, cyclobenzaprine. The efficacy and the pharmacokinetics of the extended release cyclobenzaprine, as we see here, it peaks after a few hours and then it slowly degrades over 24 hours, as compared to yellow, the immediate release, where it peaks, it drops, next dose peaks and drops, and then the next dose. So you avoid the roller coaster up and down with the immediate release. The sustained release peaks after a few hours and slowly degrades over the 24-hour period. Of course, the warning for any cyclobenzaprine product is to avoid use of alcohol or other CNS depressants. Prenorelax contains cyclobenzaprine with proven efficacy in muscle spasm management. Prenorelax provides an extended release effect, causing less somnolence and drowsiness. With a simple once-a-day dosage regimen, Prenorelax provides your patients with better compliance. Prenorelax is indicated for relief of muscle spasm associated with musculoskeletal conditions. The dose is 1 capsule once a day to be taken with or without food up to 4 hours before bedtime. So while the patient is asleep, the bioavailability will peak. And so we look at the summary of the Liptis musculoskeletal portfolio. We start with Dorfin, our flagship alpha-D-glucosamine product, which has been in the market for many, many years and is well known among the audience today. Dorfin is still your first choice for the treatment of osteoarthritis. Vaxato, 10 milligrams for the prevention of DVT for patients undergoing total hip or knee replacement, avoiding the incompatibility of injectables and the compliance issues with a convenient once-a-day oral dosage form, reducing the risk of DVT and pulmonary embolism. Prenorelax, the first and only extended-release cyclobenzaprine muscle relaxant, and Unsiatem for the treatment of hyperuricemia in patients with gout. Thank you.
Any question for Dr. Sharif? Okay, no. Dr. Ehab, في سحب على 2 شاشة و2 موبايل. حطها هنا، حطها هنا. ممكن حد من حضراتكم يجي يسحب الورق؟ حطها على الحرف، على الحرف. حد من الشباب يجي يسحب الورق يا جماعة. تعالى يا دكتور عمرو بعد اذنك. كسبني. خلاص مش مشكلة بقى. تعال مصطفى، تعال مصطفى. يلا اسحب اي ورق، اسحب اي. خلاص يا عم. بتاع عمرو. 634 يا جماعه. خلاص.
Please come up front. 634. If you have the number, come up front.
ده ايه الشاشه ده ولا ايه؟
This is
LCD?
a mobile phone.
موبايل فون؟
Yes. The winner, please come up. Please.
اوكي. اسحب رقم.
Congratulations.
مصطفى
Tell us where
رقم
you're
تاني يا
from.
مصطفى.
I'm from.
اسحب واحده تانية يلا. هنا يا مصطفى اسحب. توفيق يا حبيبي يلا. 615 615
615.
دكتور احمد فريد يلا. موبايل فون.
We have our winner, yes.
اسحب يا مصطفى واحده تانية.
Congratulations.
توفيق يا دكتور احمد. توفيق يا حبيبي. توفيق. كام؟ 50 50 50 50
50.
لا ما تجيش. مفيش 50. اسحب واحده تانية.
Going once.
اسحب واحده تانية.
212. 212.
212. يلا حبيبي اطلع. اطلع بسرعه انا. اوكي هات واحده ثالثه انا.
Congratulations.
توفيق يا حبيبي. يا مصطفى. I think this number was with Cascania. This I think 249
249.
249. طيب كان
Our last winner.
اليزاندرو. نو يلا اوكي. حبيبي لم ليبتس، ممكن تاخدوا البتاع ده عشان نبتدي شغلنا. توفيق يا حبيبي. ثانك يو فيري ماتش فور ليبتس. ثانك يو يا دكتور.
Thank you, Professor.
ثانك يو.
Thank you, Professor.
Thank you.
My pleasure. Thank you.
Next